Okay, good evening here from Amsterdam, but it can be very different times in other places. I'm going to give a very short introduction to this wonderful session with Ben Sessa and Elizabeth Nielsen on psychedelic therapy in alcoholism. So can I have the first slide? And immediately the second slide. Floris, can I have my slides?
Coming up.
Okay. So I'm Wim van den Brink. I'm an emeritus professor of psychiatry and addiction at the Academic Medical Center in Amsterdam. This is something how we think about addiction right now. So we think about addiction as a brain disorder. I would say also a brain disorder. It's not only biology, it's also psychology and sociology. But we think about the brain as the organ that is most involved. And with regard to the mechanisms, at least two important ones are hyperactive reward and motivational system and a deficient cognitive control system. And so this is how we think about the brain very briefly. Next slide. And so we can also start thinking about how pharmacological intervention together with psychological intervention can actually do something about these mental disorders. So we can, for example, with medication, stop the rewarding effect of the drug, of alcohol, by using opiate antagonists. And I mentioned there naltrexone or nalmefene, or we use disulfiram to make people feel bad if they use alcohol. And we know some indications for these medications. We can also reduce the hyperactive motivation like salience and engraving, and acamprosate can do something like that, topiramate, baclofen and gabapentin, actually all medications that work on the GABA-glutamine balance. We can also, of course, try to improve the deficient cognitive control of alcohol patients by using modafinil as an wakefulness promoting drug, and we know that especially working in impulsive patients. We can also try to reduce the hyperactive stress system, and now there is some indications that some alpha adrenergic antagonists like doxazosin can do something there. And finally, we can actually also try to use substitution drugs like what you use in opiate dependence with methadone. Now we can think about high doses baclofen or sodium oxybate in these treatments. Now the question is, can we do something about something that is really a problem in alcohol addiction? That's compulsive drug seeking, and often in the later phases of alcohol dependence. And really, I think, but that's open for discussion later, psychedelics can do something there, and we don't have any other drug, and we don't know the indication. Next slide. Now, the problem, we have a lot of medications. The problems are that they all have a small effect size, and you have to treat 10 or 20 patients to have one patient better. Also, it takes a long time before these patients get into a state of remission, and a lot of them drop out on the way. And actually, none of these medications do something about the compulsive drug seeking. So psychedelics might be a solution there because treatment is often limited to a number of sessions with low dropout. It seems, and we can hear about that later, that they have a larger effect size, and maybe via a reduction of compulsive drug seeking, they might actually do some good work there. Next slide, please. It's not that it's completely new, of course. In the 60s, 50s, and 60s, there were already studies with LSD. This is just one recent summary of these studies showing that LSD, a single dose of LSD, might be more effective than extended treatment with naltrexone, acamprosate, or disulfiram. So here shows the promise. Now, the studies weren't that great, and so we need more studies. And this was, next one, yeah. This one, a recent one, was a review on psilocybin. I'm sure we're going to hear about that more. Next one. This is a recent study on ketamine in alcohol-dependent patients. Also a first study, but very interesting to see what comes out. Next one. And of course, this is some of the results of that study. And what you see is single ketamine infusion is a promising treatment of alcoholism in this study for at least 3 weeks. Now, of course, we have to know more about the longer duration of these effects. Next one. And finally, there is the first study that Ben is going to talk more about. This is only a very short interim report about, I think, 6-7 patients. And I'm hoping that we're going to hear more of this study and with more patients from Ben later on. Next one, last one. So this is our program for tonight. Ben is going to talk about MDMA-assisted psychotherapy for alcoholism, and then Elizabeth is talking about psilocybin assisted treatment for alcohol use disorder. So this is my introduction. I'm looking forward to the new data of Ben and Elizabeth. Ben, the floor is yours.
Okay, great, thank you. Firstly, can you see and hear me?
I can hear you perfectly.
Can you see my slides?
I can't see your slides, but they will do something about it. Or you have to do something about that.
You can't see my slides?
I can't see yours.
Sorry, just a moment. Here we go. Now can you see my slides?
We can see your
I can see your slides.
So
Good. Okay, right. So my name is Ben Sessa, consultant addiction psychiatrist. Been working in psychedelic research about 10, 15 years. And I'm going to be talking to you in 10 minutes about alcoholism. So we had the opportunity to do a study on addictions, and I wanted to choose alcoholism because it's a massive social burden and problem. It's a huge, very difficult to treat disorder. I would call this a low-hanging fruit target for psychedelic research because it is so hard to treat and the outcomes are lousy. So any research that does better than the current treatments is going to do well. And how well are we doing to treat alcoholism? Well, the answer is very poorly indeed, with the very best that modern medicine can throw at you. So MAP groups, one-to-one therapy, group therapy, AA, rehab, naltrexone, acamprosate, disulfiram. About 80 to 90% of people 4 years after detox are back to their levels of drinking that they were before they started. So this is rubbish. This is rubbish. Humankind was doing better to treat alcoholism 100 years ago in the Victorian times than they are today. So anything's better than this. So we did before we did our MDMA study, we did a treatment as usual observation study. We took a bunch of people from Bristol who were daily dependent drinkers. If you look there on the left-hand side of the graph, everyone was drinking between 50 and 350 units of alcohol a week, way over the recommended maximum dose. They all went through a medical detox, so they all came down to 0. Then without any intervention, we just watched how they got on for the next 9 months. And you can see they all kind of variously relapsed at various different points. And there's the line of best fit through that. By 9 months, they were pretty much back to their previous levels of drinking. This is with, I wouldn't say no intervention, this is with the very best intervention that modern medicine can throw at people today in Bristol to treat their alcoholism. So pretty rubbish. So how does MDMA work? Well, MDMA, 3,4-methylenedioxymethamphetamine, is a psychedelic amphetamine with a whole host of different effects across a whole host of different receptors. It's much more complex than it increases serotonin, which is what the average person on the street thinks. It does a lot more than that. It has effects at 1A and 1B receptors quite markedly to reduce anxiety and depression and provide a positive affect. Mild effects on 2A receptors where the classic psychedelics work, not to the extent of ego dissolution, but to allow a rethinking of old ideas. And then it has this paradoxical stimulation relaxation effect in which the noradrenaline and epinephrine receptors are kind of in conflict with the alpha-1 and 2 receptors. So you have this paradoxical speeded up and slowed down at the same time kind of effect. And then, of course, this MDMA has this effect at the hormonal effect with the increase of oxytocin, which is the hormone secreted from the brains of breastfeeding mothers, which increases a sense of empathy and bonding. And you add all these things up, and it very cleverly, selectively inhibits fear whilst leaving the other faculties intact. Quite remarkable pharmacological effect that is, that you just turn off the fear. So here's our team. So we decided to do this. Now it's an open label safety and tolerability study. No control group, no placebo group. Now you might say that's a bit methodologically unsound. Indeed it is. But when you do a new drug in a new condition, that is the first step that you have to do. So no control group, 8-week course of therapy, male-female co-therapist pair, 2 sessions of MDMA. So that's what it looks like. Patients come in, they have their detox, so they're all heavy drinkers. They come in down to 0 at the end of their detox. They then go through this 8-week MDMA course which involves 2 sessions with MDMA, in which they take 125 milligrams plus a booster dose of half that, followed by a next day session. And then, so it's very typical with all psychedelic protocols. There's a mixture of non-drug and drug sessions. And then we follow them up at 3, 6, and 9 months to see how they've got on. I won't mention the demographics other than they were all heavy alcohol users. 14 patients taken, recruited from the local drug and alcohol service. We, in line with ethics, looked at all of their various physiology during the course of the 8-hour session, which was staggeringly unspectacular. As we get with MDMA, unlike classic psychedelics, there is a noticeable autonomic dysfunction with MDMA, mild rise in temperature and blood pressure that then kind of comes down. It's a bit like a kind of takeoff, plateau, landing effect. So that was all good. A lot of people ask, what about come downs and this low affect in the few days after? Does that make MDMA not a useful clinical tool? Well, that's a load of rubbish, actually. When you use clinical MDMA, you really do not see this affect drop that ravers talk about. Ravers talk about this drop in affect and Blue Tuesday, Black Monday, or whatever it's called. These are the profile and mood scores for 7 days after the MDMA session. These are all negative numbers. This means this is not even euthymia. This is positive mood. So patients were left in a positive afterglow for 7 days after each MDMA session, which really just bucks the trend of there being this post-MDMA affect drop. I love this table because it is so spectacularly boring in that it says absolutely nothing, which means actually it says absolutely everything, because it was a safety and tolerability study, and it was completely safe and completely tolerated across the board in all patients. No abnormal bloods, no abnormal ECGs, no adverse experiences, no deaths, no suicidal behavior, no abnormal physiological changes in MDMA. Everyone thought it was great. So that was the main purpose of the study. So here is our pooled data, our non-pooled data. It looks pretty similar to the data of the outcome study. They all came in on the left there, drinking a various amount between 50 and 350 units a week, N equals 14. They all came down to 0 alcohol at the point of detox, and then we watched them. Then they had the 8-week course of MDMA-assisted psychotherapy, and then they variously went back to relapse thereafter. And there's the line of best fit through that. And if we then remind ourselves what the outcome study was, and we then put them together, and here we go, drum roll, here's the money shot. There we go. Now, this is a spectacular outcome, okay? I feel very proud to be able to say that. This is what I call a Mithofer type result, where there's the black line, that's the typical treatment for alcohol use disorder. And the red line is with MDMA-assisted psychotherapy. That sort of effect size is staggering. It blows out of the water the current best treatments for alcoholism. Now, this was a open label, non-placebo controlled, non-randomized study, full of limitations, small number, etc., etc. We have to admit that. But what a great result. We're extremely proud of that. And final slide. Where are we going with the future of MDMA-assisted psychotherapy? Well, what we were so keen to do with this study was to show it's not all about PTSD. MDMA has been unhelpfully pigeonholed into PTSD. This is why we did this study, the first non-MAP sponsored study, the world's first addiction study, because we believe, well, my personal feeling is any psychiatric disorder that can respond to psychotherapy, which is everything from eating disorders to schizophrenia to personality disorders to affective disorders. Any disorder that responds to psychotherapy will respond to psychedelic assisted psychotherapy with either MDMA or psilocybin. That's the broad claim I'm making, which makes the field wide open for the future of psychedelic research. So let's be brave and let's do that. And we have now our clinic, Awaken, opening the world's first psychedelic assisted medical center for psychedelics, opening in Bristol. That's our building, which is currently being done up. And it's really exciting. And thank you very much.
Thank you very much, Ben. You wonderfully remained in the 10 minutes. So it's really great, great, great. And so we have a lot of time for discussion later on. And prepare for a question on on about Feribat. Is Feribat this kind of a weak MDMA, and do we know something about it? So be prepared for that question. So we go quickly to Elizabeth. Elizabeth, are you there?
I am here. You ready?
Yes, and I see you. And I see you, and you're going to talk to us on psilocybin in assisted psychotherapy for alcohol-dependent patients, and just 10-12 minutes for you.
Yes, I am. So I believe you guys can see my screen now, and there you go. Do you see it?
Perfect.
Wonderful.
Great. Okay. So I thought I had more than I could cover in the allotted time, but thankfully both of you have really filled in a lot of the background. And I'm just going to jump right into talking about what's going on with psilocybin assisted treatment for alcohol use disorder, some of the current research that's going on. We'll relate that a little bit to what Ben has just talked about. We can cover a little bit of the history and lead into that. And then I'd like to tell you a little bit about some qualitative research that I'm working on that'll help us understand what patient experiences of this therapy look like. So let's get started. My name is Elizabeth Nielsen. I'm based in New York. I'm a psychologist. I wear a lot of different hats. I am a therapist at part of the NYU team that has conducted several trials. I've been involved with the psilocybin for alcohol use disorder trial there, as well as some of the MAPS MDMA work there, and some qualitative research. I'm a project clinician at New York State Psychiatric Institute on another trial of psilocybin for treatment-resistant depression. I also train therapists on that trial. It's funded by Compass Pathways. I'm a sub-investigator and therapist on the MAPS research site, private practice site in New York. I'm the co-founder of Fluence, which is a private continuing education program offering education in this field in psychedelic assisted therapy and psychedelic integration, an advisor to Sansero Life Sciences, and a former NIH grant fellowship recipient. And I say that because some of the research that I am going to present to you later partially came out of that grant funding, even though it ended quite a while ago. So support for the research in this presentation that I'm going to be talking about today really comes primarily from Hefter Research Institute, with support from USONA, especially around the study medication. And then the qualitative research that I conduct has been funded by River Styx Foundation. We've covered a little bit about history already. Wim discussed some of the comparison between the potential for psilocybin and potential for classic psychedelics to treat alcohol use disorder in comparison to the number needed to treat with some of the approved drugs that we have for alcohol use disorder. So I'm going to get right into current research on psychedelic assisted treatment for alcohol use. And then I'll get to the patient perspectives. When we talk about why psilocybin for alcohol use disorder, this is actually from the paper that Wim showed you before, but we're seeing that the number needed to treat based on meta-analyses of studies done from the 60s for LSD was somewhere between 6 and 7 for getting a reduction in alcohol use or abstinence from alcohol use, as compared to a 9 or somewhere in that range for something like naltrexone or disulfiram, and those are the approved medications that we have on board. So we're already seeing that within the family of classic psychedelics, there is LSD, which has the potential to be substantially better than the existing treatments. And I think this really speaks to what Ben was indicating too, that there is the existing treatments are not meeting what we would like them to meet, and we could potentially do a lot better. So based on historical data, current research comes out of this and says, well, let's look at psilocybin. Why psilocybin? It's got less cultural baggage than LSD for sure. Less people know about it. It's certainly not as infamous. A great thing about it is that it doesn't last as long. LSD experiences can last around 12 hours, whereas psilocybin experiences, you're probably done about 6-7 hours in, and you can wrap up and go home at the end of an 8-hour day. And the reason that that's so important now is that the current standards of care that we need to provide for somebody undergoing an experience like this in a research setting is a really high level of monitoring and care and wraparound service and support. We need to have emergency availability services. We need to have people on call and just all kinds of protections around that. And to sustain that for that period of time for the day is more feasible than it would be if it needed to be an extended 12, 14-hour session with people staying overnight, et cetera, et cetera. So I like to point that out because it's a practicality that makes a very big difference. All of the psilocybin used in research studies is synthetic. It is not extracted from magic mushrooms. Someone will probably ask me for a comparison. It's kind of hard to make one based on a lot of variability in natural product, but using pure pharmacological grade psilocybin, we can get a very, very, very precisely measured dose, which in the studies that I'll be speaking about actually is weight-dependent dosing. So a pilot study similar in type to the one that Ben just described, but done with psilocybin for alcohol use disorder, was conducted at the University of New Mexico with Michael Bogenschutz and his team there. I did not work on this study. I did a qualitative follow-up study published on this data, but I'll review it a little bit because it uses the same therapy design as the current trial that I have worked on as a therapist. This study, similar to what Ben described in his study, was a single group design. It was open label. Everybody got psilocybin. They also got 12 weeks of psychotherapy with those 2 psilocybin sessions embedded in there. These are some of the outcomes. This was published in 2015, showing, again, those lovely, those lines look similar, except in different colors, right? What I want to point out here is that, where's my pointer? Oh, come on. No. This is actually the place where the first psilocybin session occurred. This reduction in drinking represents what happened with just people coming into the study and having psychotherapy in that anticipation of having the psilocybin session. So you're already seeing some reduction. So this is our actual baseline here for the psilocybin treatment. What I love about this study design is that it's actually detecting not just abstinence only as an outcome, but actual reduction in percent of drinking days and percent of heavy drinking days, because we can actually detect a lot of really meaningful, clinically meaningful outcomes that are not necessarily 100% abstinent. And to do so, I think is extremely important because it values incremental change and the kind of change that we actually see naturalistically in people's drinking histories. So really like this design, really like that aspect of it. What does the therapy look like? Got two different therapists in the room for all the sessions. We've got 2 kinds of therapy. And again, if you want to read more about this, check out the Bogenschutz and Forsheim's article from 2016. There's 2 kinds of therapists. One is focused on providing an empirically supported treatment intervention for alcohol use disorder. And another is really focused on the preparation, support, and integration of the psilocybin experience. So that's really the psychedelic therapist part. However, in the room, both therapists work very much together in conjunction in a coherent way and present a coherent experience for the participant. There's our room. You've probably seen these pictures elsewhere, but it's a very nice living room-like comfortable setting. It's quiet. It's designed to facilitate introspection. So the double-blind trial that's been going on for the last several years that I have worked on at NYU as a therapist was a randomized controlled trial. So half people have received placebo, and there's an ancillary study going on, a neuroimaging study, as well as an ancillary qualitative study that's the one that I'm designing and working on bringing through the process. This study actually has finished recruitment. So right now we're in the data wrap-up, data cleanup, and data analysis phase. So I'm not going to say too much more about it, but please stay tuned because I'm really looking forward to seeing the results, and I'm sure you all are too. This is an overview of what the study looks like. You've got 3 different periods where 3 different psilocybin sessions, rather. The first 2 are randomized sessions, and people are randomized to either the either the psilocybin or placebo. And then there's an open label session at the end. So everybody gets at least one psilocybin dose. There are 2 fMRI sessions that are, again, elective. And at the end, after that third session, there's the option for the qualitative interview. So what about some patient perspectives? Again, really quick, I did a qualitative content analysis looking at 17 debriefing sessions, or sessions that occurred the day after people's psilocybin sessions in that first pilot study. We looked at participant comments, how people actually describe their experiences of ego dissolution. How do they describe their experiences of changing their relationship to alcohol? How do they describe their experiences of commitment to change, dysphoric experiences? If you're really interested in hearing some patients' perspectives and actual words about this, this is a great article to look up, and really also talks about what this means in terms of what you're listening for as the therapist. I'm going to skip that because it's just more numbers. This is, again, our treatment room. Wanted to give you a visual of what the patient experience looks like. This is members of our team, Sarah Menenga, Michael Bogenschutz in the middle, and Samantha Padra-Barrick, who also work on this study for a very long time making it happen. Why do we think this might work? Well, there are a couple potential theories. It could be that there's this mystical experience that's so central to the AA model that happens during these psilocybin sessions, and that really shifts people in a spiritual way. Other psychological factors: increased self-efficacy, increased motivation, insight, acceptance, compassion. These are all kinds of psychological factors that we know could be potentially related to change. And then there are, of course, physiological mechanisms. There's receptor modulation, neuroplasticity. I tend to think of all of these things working in conjunction and enhancing each other as one big package, right? So you've got that therapeutic environment, you've got the potential psychological factors that help people engage with the therapy, and maybe, take those insights one step further in terms of how they implement them in their life. Second qualitative study going on. This one we actually just finished data collection for, so conducted 13 semi-structured qualitative interviews with people who completed their third psilocybin session in the double-blind trial. Worked on this over the course of several years, and again, we're in data analysis, we're working on the coding, but this will give us a really nice rounded view of what it's like for people to go through this therapy. Perhaps what some of the things that they would have liked to have been different about it, or what they actually really appreciated about it from their perspective. And this study is also looking at changes in people's experience of self-compassion, so compassion towards themselves, as well as people's experiences of stigma. I actually think that stigma is going to be potentially one of the biggest barriers to making this accessible as a treatment for addictions, because addictions are such stigmatized category of types of problems to have, and have historically been extremely stigmatized, as well as treatments for them have met with stigma as a barrier to dissemination. So we're looking at stigma, we're looking at compassion, and we're looking at people's overall perspectives on their experience. What does the future hold? Well, earlier in these days or later this weekend, you'll probably hear, I know you'll hear at some point about smoking cessation and cocaine use disorder trials that are going on. So I refer you to Matt Johnson, Peter Hendricks for more about that. I hope to see more. I hope to see more research on psilocybin for addictions, and I hope to see more research on how we can shift the paradigm and start thinking about what we classically thought of as a drug with no potential medical value at all, to something that could actually heal some of the worst types of suffering that we're seeing in our lives and in our societies. So with that, I'm going to wrap it up and skip that because we pretty much already covered it. I want to give a special thanks to the NYU research team, Michael Bogenschutz especially. Sarah Menenga helped prepare stats and slides, and all the other fabulous folks I work with there, as well as everyone who supported this study. All of this research is coming through philanthropic support, donations, and help through foundations, and especially big thank you to ICPR for making this happen. The Open Foundation having been a great support to our work. So I'll take it there. Wim, you want to?
Thank you. We have actually very well done. We have another 10 minutes for discussion. So Let me start with both of you. Ben, you later in the coming studies, and Elizabeth, in your studies, you used another medication for blinding. Do you think that you were successful in blinding the study? Because in the long term, they're going to ask us these questions. Elizabeth?
So yeah, so the double-blind trial did use a placebo, and it's interesting. The procedures are precisely the same no matter what, right? The therapists don't know what the participant is getting. The participant doesn't know what they're getting. So we go through all the same procedures and give all the same types of instructions. And I genuinely do believe that we don't know what people are getting. And the interesting thing about this study design, and I have not seen this in all studies, but I have seen it in this one, is that both the participants and the therapists are asked to guess what they thought they got. So we will actually be able to go back and look at that later and see whether or not they were correct once it's unblinded.
My guess is that they will not be better than chance, but let's see. Benny, you just had the same idea that at least this is one way. Another way would probably using more objective outcomes in order to prevent information bias. How do you think in the next stage of the studies, Ben, that you're going to do it?
I think this is a really important point, and people often ask it. First thing to say, it is not unusual in psychopharmacology research for blinding to be difficult. It's difficult to blind all kinds of pharmacology research studies. It's not peculiar to psychedelics. Secondly, like Elizabeth says, people do not guess as often as you think. It's not always so obvious. It's not obvious at all, in fact, and it doesn't make a great deal of difference. So I think, and thankfully, the regulatory authorities and the ethics committees don't make too much of a big deal about this. The point is, you're demonstrating that the treatment works with the drug. Well, another way of doing it is by just having different dosing regimes. So instead of a different active placebo, something completely different like nicotinic acid or methylphenidate, you just use low dose MDMA, 5, 10 milligrams, 15 milligrams. So they all get MDMA. It's just some are getting a therapeutic dose and some are not. So the blinding thing isn't such a big problem. Okay,
let's hope so. Let's hope that the FDA and the EMA will think the same. So I got a very interesting question. I want to answer both of you. It's outside your scope, but it's a challenging question. Do any one of you believe that schizophrenia can be treated with or partially treated with psychedelic psychotherapy?
As I said, I think we are in the infancy of psychedelic research, and at the moment, all psychedelic research protocols have psychosis, so schizophrenia, bipolar 1 as exclusion factors, and that's really a kind of ethics committee risk aversion type approach. Psychedelics are not that psychotogenic, yeah? We know, as psychiatrists, we know what the 3 big psychotogenic drugs are. They are cannabis, amphetamine, and cocaine. Those are the ones that put people into hospital with psychotic episodes, not commonly psychedelics. So I am quite certain that in the next 5, 10, 15 years, we're going to see research protocols for treating aspects of psychotic disorders. And there's already some interesting research being done by Benjamin Mudge in Australia, looking at ayahuasca as a treatment for bipolar 1 disorder. So it will be coming. We will be less risk averse in coming years, and let's hope so, because there's a lot of people with psychosis who could benefit.
Any comments to that, Elizabeth?
I completely agree with Ben. I also want to add that there were trials of giving people LSD and other classic psychedelics for psychosis or other psychotic related disorders in the 1950s and 60s. So there's probably some historical research that the asker might want to dig into.
Yeah, they were not successful, actually. I think they showed higher levels of relapse, but I think there's some recent studies using psychedelics on top of a stabilized patients with antipsychotics, and they saw reduction in negative symptoms. So I think it's open, but the most important thing is we don't have to exclude all these patients with a history or a family history with dependence. There was another question, Ben, for you, and I'm not sure that I already announced it to you. Any research on nootropic drugs like Phenibat that might have a kind of a short weakened effects like MDMA?
I'm not aware that phenibut is anything like MDMA, to be honest. It's a
No.
GABA agonist. It's more like a benzo. It's not licensed as a medicine in the EMA or FDA. It's used in Russia and it's sold elsewhere as a foodstuff. I can certainly say with certain there are no psychedelic protocols anywhere in the world suggesting phenibut. There's 1,000 different drugs I'd choose before phenibut as a potential.
I would agree with that. I think there are studies with sodium oxybate, and I think that's much closer to the phenibut, because it's basically a GABA B1 agonist. So okay. There's more questions. In both of your studies, did patients have previous experience with psychedelics? And if so, did you see any effect of that? Did you see differences?
Do you want to go, Elizabeth?
Yeah,
begin.
sure.
You can begin.
I mean, this is going to be an entirely anecdotal answer, and I'll just speak broadly about, let's say, all of the studies that I've been involved in, which is 5 or 6 trials by now. By and large, a lot of people are coming into this, what we would call psychedelic naive. Studies have different, which I can't speak to, a certain rule out criterion and exclusion criterion. But by and large, people are psychedelic naive. There are some coming in with some history of some use of something at some point. And the only thing that I, anecdotally again, might have noticed is that with a little bit of familiarity, perhaps there's a little bit less anxiety for some people. But it certainly isn't considered something that is necessarily going to make a massive difference. But then again, it is something we're documenting. So if we do find a difference, that will be really interesting. Studies haven't really been large enough to document a difference yet.
My answer to this would be the differences between recreational use of psychedelics and clinical use are vast. I'm happy to go on record to say that I have taken ecstasy in a non-clinical setting, and I've taken clinical MDMA legally in a clinical setting, and they really are not comparable. If you look at the way people take ecstasy, it's all about externalizing behavior, dancing, shouting, having sex, lasers, music, banging dance floors, drinking, taking cocaine and other drugs. When you're lying on a bed in the dark with headphones on and eye shades in a clinical setting, the subjective psychological effects are really not like raving. So it doesn't make a lot of difference whether or not someone's previously had ecstasy experience when they come in to have clinical MDMA experience.
Okay, maybe a last question was some people were asking that, do you think that in treating alcohol or other substance use disorder patients, do you think the psychedelics is working on a specific neurobiological mechanism? I myself have been thinking that because the psychedelics, they seem to work almost in any psychiatric disorder, maybe there's some underlying P factor, something like compulsive thinking, like you see it in depression, in this rumination, you see it in psychosis with the delusions, you see it in OCD with their obsessive compulsive thoughts, and you see it in addiction with all these this craving, which is a kind of a compulsive thing. Do you think that all these psychedelics could actually target this kind of underlying compulsive behavior and thoughts, not getting out of this same stream of thought? Or do you think it's just much more general than that?
I think that it's working on many levels, and in some ways I don't care. The point is they work. I think we're obviously using MDMA as an adjunct to psychotherapy, and we're using it as a tool to increase empathy and understanding and reduce pain and allow a patient to engage in effective psychotherapy. And what it's doing neurobiologically, we know the mechanisms by how it does that in terms of turning off the amygdala. It may be having some other hidden physiological effect, but the point is you only take it for 6 hours twice. I don't think that's going to cause demonstrable and lasting brain effects without the added psychotherapy. So I'm less interested in what's happening biologically to change addictions. What we do know is it works very, very effectively as an adjunct to psychotherapy, which does very effectively change addictions in a lasting, long-term way.
Elizabeth, any additional comments?
Excellent answer. I mean, I'm in full agreement. I would say that psychedelics perhaps psychologically help people understand themselves and their relationship to whatever they're struggling with in a different way. And that's something that can be applied very, very broadly again.
So if I bring it a little further,
Can I make a really quick comment on one of the Q&A questions about risk of neurotoxicity with MDMA? The answer is no, it's not. Go back 20 years ago and the pharmacology community was split 50-50. You ask the pharmacology community today, it's like 98-2 in favor of MDMA is really not neurotoxic. And the other thing is when you're talking about medicine, we don't use broad terms like safe or dangerous. We talk about risk-benefit analysis when you weigh up the costs and the benefits compared to not treating the disorder. And finally on this, have you seen how neurotoxic carbamazepine is, olanzapine, or let's face it, vodka? So we do not need to be scared off by stories that came out of the early 90s about neurotoxicity. We need to wake up.
Fully agree. Maybe we get the time to answer this question. We're a little over time. The question is, if you say it's all general, but I'm sure not, we see very nice effect sizes, but it's not a magic bullet and not all our patients are going to do well on it. You think there will be a profile that might benefit from it and another profile that is not doing so well with psychedelics? Is there any indication of that? Elizabeth?
I didn't quite catch the word you said, a
Is there a
diagnosis.
patient profile that you say might benefit more, patients that benefit more from psychedelic treatment than other addicted patients? Because that's what we start to see. Personalized medicine is getting popular.
You know,
And so-
I'm not quite sure I could quantify that, but what I will say is that I think it's very important that somebody actually be fully willing and desiring to go into this process, because it is not a treatment that you just sort of give to somebody and then, you know, will observe the effects. It really requires the patient to be motivated to engage with the content and to engage with the therapy and to engage with the process. So that's something that I could say is probably going to be critical for folks. But as far as a particular type of problem, no, nothing specific to identify.
Yeah, do you know what? Everyone's talking about the psychedelic renaissance. Great book, by the way, by that. Let's change this. I think we should be calling this a psychiatric renaissance. Psychedelics are excellently placed to change the whole paradigm with which we look at mental health. We must disregard categorical diagnoses. I've been a psychiatrist for 20 years. I've never met a patient with depression or anxiety or schizophrenia or bipolar or an eating disorder or an addiction. I've met thousands of idiosyncratic clusters of people who require bespoke personalized care plans in which they teach the doctors what they need to do. We need care plans to be designed around needs, around social and psychological issues, not diagnoses that have been fabricated by pharmaceutical companies to sell particular products that are rubbish and don't work and mask symptoms. This is a renaissance of psychiatry, not a renaissance of psychedelics.
Thank you very much. And thank you very much in making clear that we are on really a new phase in psychiatric thinking and psychiatric treatment. But actually what you also both showed very clearly that we do it with excellent methodology, because that's what we need in this time, but it will be revolutionary. So thank both of you very much. I think there are places in the surroundings where you can actually go on chatting with each other on this issue. Right here and now we have to stop. Thank you both very much for excellent presentations and for answering questions. There are many more questions in the Q&A box, and please meet in the meeting boxes elsewhere on the program. So thanks a lot, and bye-bye.
All right, thank you.
Please let me
One thing.
one more thing. So thank you all for the beautiful panel and for the beautiful talks. We have 10 minutes of a break and we will have some music. And afterwards, we will have a setting track with Mendel and Ido talking about the importance of setting. And also another thing is the poster session. So you can go in WUFA to the poster section and you can vote for your most favorite poster. And if you do this before at the end of the big break tomorrow, the 10 best posters will be selected and a couple of them will receive a prize. So please go there and check them out, and we will see you after the break. So thank you very much.
Okay, bye-bye.